Okay, agenda. Thank you for coming. Definitions and criteria. I'm going to repeat something we did yesterday, and there'll be a test afterwards for everybody that was there yesterday, and a test for you guys that are seeing it for the first time. Then we're going to talk about catastrophizing. Does everybody know about catastrophizing? Oh, it's the revolution in fibromyalgia. Tenderness, yeah. Please show some. And then a little bit about exercise so I can get a few more people into our study. We're down to our last half dozen now, so you can join if you hurry. Okay, diagnostic criteria. History of musculoskeletal pain, shifting in location, exacerbations with cold, stress, noise, temporary relief, morning stiffness, chronic fatigue, poor work tolerance, non-restorative sleep, initiation of symptoms with emotional, physical trauma, worsening. It's as if it's exertional exhaustion. Is this a pretty typical definition of chronic fatigue syndrome? Is everybody pretty happy with this new definition? Yeah? The important thing is it actually has physical findings associated with it. The current ones don't. Normal findings in the joints, muscles, tenderness over tender spots, as they were originally called, depressed affect, and temporary relief with trigger point injection. And of course, normal blood work. So you guys are all familiar with this new criteria, right? For chronic fatigue syndrome? Right? You can shake your head, yes or no. Well, it's for fibrositis from 1981. But yet, I found that this is often the best criteria that I've seen as far as describing to patients what this illness is all about, or shall we say illnesses. I think one of the challenges that we have is that we've got a number of syndromes that overlap. Can we separate them? The issue was raised before, if we do clinical studies, do we need a comparison group, a comparison patient group? Maybe we have some here that I'll tell you about in just a moment. So fibrositis, it got started in the 1840s with a German physician who identified tender spots in muscle tendon junctions. Fibrositis was officially designated by Gowers and then Stockman in 1904, and not much has changed in the definition from the one that I just gave you from Bennett in 1981. It's a nice article by Kelly in 1945 that also reinforces these same trends. The evolution of fibromyalgia changed in 1990 when that definition was stripped down to having widespread pain, left and right side of your body, above and below your waist, and the axial spine, including the ribs, with tenderness. When you would press with your thumb, tenderness at 11 of 18 tender points. You're all familiar with that? Have you ever been pressed upon by anyone other than me? So, do you know if you have fibromyalgia? Okay, so should I go around pressing people? So, you press with your thumb. Go ahead and press on the back of the seat in front of you. And if you press until the nail blanches, that's about 4 kilograms. Go ahead, you can press the chair. I checked with them. The civil engineers said that the chairs were built okay. If your nail blanches, that's about 4 kilograms of pressure. If that causes pain, then that's a positive tender point. We can try to move a step away from that and do dolorimetry, which is where we take a stress gauge, press on these standard locations, and see how many kilograms of pressure it takes to cause pain. Now, it sounds barbaric, and it's kind of old-fashioned, but it actually is helpful, and I'll show you in a little bit why. This diagnosis is sign and symptom. So symptom of pain, sign of tenderness. The tenderness is important because it implicates the mechanism of systemic hyperalgesia. Systemic hyperalgesia being related to changes in the dorsal part of the spinal cord and higher parts of the brain, where signals that normally would not be painful now become perceived as being very painful. Hence, a small amount of pressure produces a large amount of pain. You can track this pathway, this network that leads from a pressure being applied, for example, through the brain to where it will enter your conscious perception in the anterior insula here. And the pattern in fibromyalgia is very similar to what you find in other types of chronic pain. Now, there was a change in 2010, 2011. The rheumatologists decided that tender points were difficult to do, not reproducible, and they were just part of a normal distribution that I'll show you in a little bit later. So they also discovered that this tenderness was related to catastrophizing, a psychological construct that I'll show you. And into their diagnosis, they added fatigue, cognitive problems, fibrofog. Who's heard of fibrofog? Okay. Fibrofog is like brain fog. Duh. And sleep disturbance. Is it starting to sound like there's potential for some overlap? So what's catastrophizing? I'm not very happy about this change that's occurred here and the apparent explanation for it. This is a questionnaire, 13 items, self-report. I'll show it to you in just a second. It has 3 subscales of rumination, magnification, and helplessness. So it may be useful. A high score is 16 out of 52. This doesn't reproduce very well. Maybe the fuzziness is telling us something, or I don't know. But it asks questions like, I anxiously want the pain to go away. And then you give a response from 0, 1, 2, 3, 4 of whether you agree slightly, very strongly, or it's there all of the time. And then you sum up the numbers, and that gives you your catastrophizing score. If it's above 16, then you're a catastrophizer. Thank you. Thank you very much. Now, what's interesting, though, is the responses on this questionnaire turn out to correlate with some of the genes that are expressed in the peripheral blood mononuclear cells that Eliza and others have spoken about earlier. Are they spurious connections, or are they real mechanistic insights? I don't know, but on the right side there you can see 5 particular genes that have been linked to catastrophizing. So I stayed up last night to take a look at our catastrophizing scores and just get an idea as to how they are distributed in our patients. So we've got a large database. This is data from about 500 people, I suppose. Only 14 were fibromyalgia people. They're the blue diamonds on the left. So the 95% confidence intervals are quite wide here, but half of that group were catastrophizers. GWI is Gulf War illness, which I'll tell you about in a moment. And you can see that they have a higher level of catastrophizing. The chronic fatigue syndrome group were kind of slightly lower than the fibromyalgia. And then our controls, the black dots, have scores of about 8. They're the lowest. The bars link groups that are statistically significant after Bonferroni correction for multiple comparisons. I'm sure you'd want to know about that, right? Okay. So the rumination, magnification, and helplessness followed the same type of pattern as this overall sum. And it suggests that the fibromyalgia, the Gulf War, and chronic fatigue group may be kind of comparable in their responses to this questionnaire. So is fibromyalgia special for having an association or not? I don't want to go there too much, but we'll see about that. Now, what about the name myalgic encephalomyelitis? This will get me into hot water here, I think. This goes back to the description of several acute onset epidemics, particularly affecting nurses who took care of patients in polio hospitals, where often there was fear of an acute poliomyelitis outbreak, and this led to many of the nurses being admitted with symptoms of an acute illness. The 5 of these epidemics from the 20s and 30s were reevaluated, and they now appear as if hysteria was being reported. I think that this is an unfortunate link that is a legacy that is an asterisk tagged on to the ME name. It was really, I think, Carruthers that brought the title back in, and I can only hope that we do justice to you by reevaluating this earlier link and getting away from the story of hysteria. In the 1990s, Fukuda, working with Bill Reeves and company at the CDC, out of the viral epidemiology branch, were investigating outbreaks of what you know as chronic fatigue syndrome, ME. They found it was more an endemic form with some specialized outbreaks that may have been in clusters, may have been in infectious clusters. But the way that they did the investigations leave me to wonder if their preconception was that this was a viral syndrome occurring in clusters, leading to acute fatigue, sore throats and sore lymph nodes, and then 6 other complaints that were identified with high prevalence in their patient groups. I'm sorry if that's a little bit heretical, but to me it speaks to the need to have much better diagnostics than just these criteria we're using. I think Bruce Carruthers' really big contribution was to emphasize the post-exertional malaise as being a key thing, a key finding that separates this illness from others. And also to emphasize the autonomic dysfunction that has been alluded to as part of many of the functional somatic syndromes. You're all familiar with the Institute of Medicine diagnostic criteria, the SEID, Systemic Exertion Intolerance Disease, and I think there was a very good effort there to make it a disease so it could be treated as something more legitimate and better accepted by the general public and the press. I'm surprised that it has been assailed as hard as it has by people within the CFS community. because the claim being that in its current form, you can be depressed and satisfy the criteria. I know that firsthand because that's what the guy wrote in one of my reviews that got rejected recently. If you read that report, though, it tells you that the SEID report, the IOM report, is a work in progress. There wasn't sufficient data to evaluate pain, so they haven't discussed pain, and it's not part of the criteria. Their intent is that they will go and relook at the information in 5 years, now in 4 years, so clock is ticking for us all to get our new publications out that help to extend our understanding of the symptom profile in these illnesses. So does anybody remember the Gulf War? Yeah. Okay, so the Gulf War, to me, well, this is the first one. Was it the Justifiable War? Whatever. We'll not go there, okay. So the Gulf War, 1990, 1991. The military, as they went in there, were given anthrax shots, gamma globulin shots, many other vaccinations. When they were deployed, it was hot. They were working hard, long hours. That's a significant stressor in and of itself. They were given pyridostigmine bromide pills. Pyridostigmine bromide is a reversible acetylcholinesterase inhibitor. They were told to take one at a time, but hey, if nerve gas is going to kill you, why take one if you've got a blister pack of 8? Take 8 at the same time. Chemical alarms were going off, and then after the war, the 82nd Airborne blew up a huge munitions dump at a place called Kamasia. And there was a huge plume of sarin, mustard agent, and other nerve agents that blew across Kuwait and at least 200,000 military that were there. We now have an attack rate of 25 to 32% of those who were deployed who are now affected. It's kind of a high attack rate, don't you think? I mean, it would be that way if the House of Commons if 25% of them suddenly got sick with an ME-like illness, there might be some funding for it.
I don't think we missed them either.
So the symptoms that they had, they used the same criteria, the same questionnaire, the same system as the CDC had used for defining chronic fatigue syndrome. But Lee Steele, who did this in divisions in veterans in Kansas, came up with 6 regions, and you had to have multiple symptoms in these. I won't go over each and every one of them, but they would be very familiar to you as you look through this list, because many of them are present in all of the CFS-ME people at one point or another. The numbers that are after this are the odds ratios for the attack rate, the onset of these symptoms compared to the non-deployed military. So let's go back to the tender points. This is the first, oldest diagram. Again, it's from Bennett's paper. It's the first one I could find of the tender points, and this has now gotten incorporated into American College of Rheumatology lore. You see it all in many of their handouts to highlight where the tender points are. Again, at those places, you press with your thumb, and if it blanches, that's about 4 kilograms. Or if you take a strain gauge and press over those points, you can see how many kilograms will produce pain. So do you know what the range would be in the population? Well, we've had people come in where we'll give 12 kilograms of pressure and they don't budge. We have people that you put the gauge on their skin, and it's painful. So that's the whole gamut. The two people who've been most tender, one was Special Forces in the Gulf War, the other one jumped out of airplane, parachuted into the jungles in Panama and into the Gulf from the 82nd Airborne. Now his clothes hurt him. That's, I think, a concept that you guys will be familiar with. Yes? The tenderness? Okay. So here's the distribution of the average kilograms causing pain. The squares, the white squares, is the wide distribution in 212 women that we evaluated. The blue peak, the black peak on the left, is our fibromyalgia group. The red group are chronic fatigue syndrome. And this is a distribution so that as you go from very low pressure to cause pain up to high pressure, you can see you start with a few people, it goes up to a peak about here, and then comes down at high pressure. And then for the fibromyalgia group, it goes up and it comes down. However, it turns out that if you use this blue line, the 4 kilogram cutoff, you've got a really good measure for diagnosing this condition. That's indicated by the receiver-operator curve over on the right. We won't go into the statistics of that right now. It's a problem, though. If you have people where you've been pressing on them and 11 out of 18 places are tender with just your thumb pressure of 4 kilograms, if you average, and that's your definition of fibromyalgia, if you do that same testing this way with the dolorimeter, you mathematically end up with an average that's under 5 kilograms. Therefore, you can never have people with fibromyalgia who would have a curve that extends to a higher kilogram level. This group is false positive. They're just an artifact of who is tender when you press with your thumb. And it's that reason that led the rheumatologist to get rid of this sign. It's very good for selecting older women with fibromyalgia because their tender points go up with age, and women have more than men do. But it's not good for identifying men who have fibromyalgia. So they've gotten rid of that sign, the only sign there is. And they also justify it because it's related to catastrophizing, but I don't think that's a good justification. So what happens with the chronic fatigue women? When I was doing these, it was my personal impression as I pushed those gauges that the women with chronic fatigue were more tender than the controls we had. So imagine my surprise when I actually did the data, did the statistics, and found that the women weren't nearly as sensitive as I thought they would be. There's the red curve there, and it turns out that that red vertical line is a cutoff point, a threshold that you could use to get kind of a poor way of identifying chronic fatigue syndrome people. Now, that means that the dolorimetry probably is not very good at diagnosing these illnesses. And it raises the whole point of what's this systemic hyperalgesia, this alteration in the spinal cord that may be leading to the pain, or may be associated with the pain sensations that occur in CFS. The one place, though, that we did discover that this could be useful is in the Gulf War illness women. because there we just looked at their pressure sensitivity. And in them, we found that they pretty much were all to the left of that 4 kilogram line there. So that I think they represent a different pathogenesis, a different form of disease where they have something wrong in the signal conducting system leading from their spinal cord to their brain, so that now they have increased pain that's related to the tenderness as well. And it may become a positive sign that people in the Veterans Administration's hospitals can use to diagnose this. That would be very good, because right now those people are pretty much, they're treated pretty much the way you are by many of the physicians, just disregarded and told they're nuts. Okay. So any questions about tenderness? Save them till after. Okay. So exertional exhaustion, I think, is the whole crux of this, and that's why we designed our 2-day bicycle magnetic resonance imaging study. We have people come in, we screen them, do lots of blood work, do an MRI with a cognitive test, do exercise testing. Then the next day we repeat the exercise, do the MRI, and then everybody who wants to gets a lumbar puncture. We'll throw it in for nothing. I'm going to use this to show some results we had about what happens with postural tachycardia. Does anybody here have POTS? Does anybody here feel dizzy, woozy when they stand up? Have the orthostatic changes? This we started to look at in order to try to get an idea about what the mechanisms might be. So Betsy Keller was here last year, and she talked about the maximal exercise stress test, where on the first day people would go to their max. They'd have their VO2 would be measured. Then they would try the next day, and their VO2 would be about 15% lower. And that was an indication in chronic fatigue syndrome that there was some change that was reducing your ability to do work. I think it's an open question as to whether that's muscle, mitochondria, or some other mechanism. When we do our submaximal tests, we don't see that effect. In fact, people do pretty much the same on the first and the second days. So whatever our stressor is not sufficient to cause these bad VO2 changes. However, they are sufficient to cause changes in the blood flow in the brain, particularly when you do a cognitive test. So we found that about 25% of our patients had postural tachycardia. Now, usually you have to do a tilt table test to be sure about this, but we did this really, really expensive thing where we'd have people lie down for 5 minutes, and then we'd have them stand up, and doing this very difficult task. It only took us 2 years to teach our nurses how to do it. You don't know our nurses, I'm sorry. Never mind. Okay, so you do that, and 25% of the people had an increase of heart rate of at least 30 beats. That's the definition. We had 2 healthy Georgetown undergraduates who developed postural tachycardia before exercise, so we don't get Georgetown undergraduates anymore. Okay. We've only had 1 patient who's developed hypotension. Beforehand, that was another undergraduate who we reversed their hypotension by giving them Gatorade. Vitamin G is our great discovery and contribution to our therapeutics for CFS. I wish we had something better right now, but it's a step in the right direction. If you're feeling weak and puny, take some lemon lime Gatorade. 16 ounces, and it refreshes you. It's not my word. That's what Dan Peterson told me. So it's got to be right. The other thing, we did this study first in Gulf War people, and we identified a very odd phenomenon that hadn't been seen previously. And that was that when people did stress tests, about a third of the Gulf War people developed tachycardia after the exercise. This, to our knowledge, hasn't been reported previously. So it's of great interest to find out if this occurred in our CFS people, and sure enough, half of the folks get it, and 0 of the controls. Again, after exercise, we've only had one person who's had a drop in their blood pressure when they stand up, and that occurred when their heart rate dropped, or heart rate raced up by 40 beats. So they have a very bad autonomic dysfunction problem. In order to study this further, we're looking at the heart rate variability, and I'll show you a slide of the preliminary results. Heart rate variability is where if you look at an EKG, if the rate of the EKG is getting faster and faster and faster over the course of 10, 20 heartbeats, then it suggests that the sympathetic nervous system is speeding the heart up. If those EKG beats are getting slower and slower, it suggests that the brain stem is sending a message through the vagus nerve and slowing your heart down. By computing those rates, you get an idea as to what the brain stem is telling the heart to do. This is our simple test, and in the red triangles, you can see the start people, the reversible tachycardia people, showing an increase in their heart rate. Okay. Starting at the top left corner is the heart rate change in our groups of people. We, for this, I combined our controls and the people who did not get the tachycardia together. We call them the stop people for reasons I won't go into. And our start people in this case are the ones with the tachycardia. So you can see it at baseline, before exercise, which is the left 2 pairs on each graph. The controls and our start people are normal. But then after exercise, our heart rate goes up significantly in the start folks. While in the top right diagram, we're measuring the change in the sympathetically influenced measure. It's called LFA. This is the change between lying down and standing. And you can see the controls have a before exercise, there's no significant difference. In the controls, the red box, they have no change after exercise, but you can see a significant increase after exercise in our start people, suggesting that they have an acceleration of their heart due to increased sympathetic drive. In contrast, the parasympathetics, which slow down the heart when you, they're actually turned off in both groups when you stand up. The result is a greater imbalance in this subset of people who get a fight or flight type reaction just because they stand up. Right now? Not for you, sorry. Okay, you want a climax? Here we go, synonym of the acronyms. So the key thing from this is the exertional exhaustion, I think, is unique potentially to the people who meet the CFS-ME definition. And it may be that the tenderness, the fibromyalgia component, is an interesting but maybe irrelevant problem. It may turn out to be important for the pain, but I'm not even sure if that's the case. We have more studies to do. The Gulf War people definitely have systemic hyperalgesia, they're more tender, and they have many severe symptoms that are indistinguishable from CFS-ME. And finally, discovering this subpopulation, this reversible tachycardia group, I think is very instructive in telling us that there's something wrong with the brainstem. And to go back to one of the earlier Invest in ME meetings, Barnden reported by internet reductions in the size of the brainstem, atrophy of the brainstem in CFS. And I think that's starting to pull this edge of the story together. Thank you very much.
We've got time for a couple of questions if you'd like to ask. Yes, one here.
With ME patients in the beginning, especially if they have been exposed to xenobiotics, there's a lot of throat pain and discomfort, which may be related to toxic mucous membrane irritation. Is there any findings? I have heard this hypothesis once, that from there, from the throat, the back of the throat, the toxins can move retroaxionally along those nerves into the brainstem. Could that be the way the pathology occurs in the brainstem?
It's possible. The way that we've looked at it is is through the nasal nerves and the olfactory nerve. There's supposed to be a brain homing peptide that you can attach to larger molecules, and if you spray it in the nose, it will carry the chemical, the protein up to the brain. However, I think there's other more likely mechanisms blood-borne through the brain stem, through the blood-brain barrier. The point, though, is that, as Maddie pointed out, there's regions of the blood-brain barrier that are near the areas of atrophy that are seen on MRI that don't have a blood-brain barrier. And that's where, for example, you'll eat some plant product, an alkaloid that will make you sick to your stomach, give you nausea, vertigo, you'll vomit, and that's because that chemical was able to directly diffuse into these chemosensory regions in the floor of the fourth ventricle. That may be a much better route.
Okay, thank you very, very much, James, indeed. Thank you.